My charge is to talk about osteochondral allografting, which is a favorite thing of mine, particularly in other joints. So I'm not going to, how am I going to fast forward here? Are we moving? How do we get the screen to go forward here? There we go. Slow. Sorry about that. Go back. So my disclosures are available. They're not much related to this. Everything I know about allografts is available to the general public. I don't receive any funding for any of this kind of work. So here's the story of the patient we're going to talk about. And I'm not a foot and ankle expert, but I do agree with the principles that have been outlined already. I will make a couple comments. To be controversial, I'm not comfortable with OAT as a knee surgeon because I think donor site morbidity is underreported. And I think there are some anatomic and biomechanical compromises. I usually see patients in referral with big lesions or missing bone. And to me, it makes complete sense to repair that defect with a anatomically identical graft of bone and cartilage. And that's why I prefer a Talus osteochondral allograft. There's been a bit of science this morning. I'll add my part to it. Osteochondral disease, I have a great interest in, and we have to remember that the osteochondral unit is integrated organ system, very interdependent structure and function. And these osteochondral lesions that we're talking about are a very prototypical osteochondral disease. So it's an organ failure rather than a tissue failure. And that's why I think that replacing it with a light organ is reasonable. This is probably my favorite paper you've never ever read. It's hydraulic conductance is a concept of the ability of fluid to pass through a cartilage surface into bone. And I think it's probably the most likely mechanism for cyst formation. And what I want to show you here is in a partially eroded or a cartilage lesion, the conductance is 10,000 times greater than in intact cartilage. So these osteochondral lesions, I think this is how they form. And doing a surface treatment might not always fix the hydraulic conductance issue. And finally, I want to say osteochondral repair has many advantages. You get your mature hyaline cartilage. You don't need cellular tissue differentiation. And you get a bone healing paradigm. And even though the talus is a difficult bone, bone healing to me is a lot easier than cartilage regeneration. And I think that the faster and simpler rehabilitation for this over cell-based therapies is quite attractive. I also want to say that a shell or a small fragment allograft is not bulky. Everyone uses the term bulk allograft, but to me, a bulk allograft is a tumor surgery. So I like the term a small fragment or a shell graft. As you can see here, a few examples of what I'm talking about. These are relatively small, not that much bigger than 2 oat plugs, actually. My preferred technique for this is actually very low morbidity, an anterior approach without a malleolar osteotomy, external fixation when necessary, but just using joint distraction, plantar flexion. I onlay the graft, fix with metallic screws, and I've used all kinds of fixation, and then back to countersinking small screws, and then a short period of non-weight bearing of 6 to 8 weeks. And we have a video of this technique that's available online. Here's a typical example of what we might do: a large cystic lesion, resect the shoulder, match it, and then place it in one screw. And it's technically fairly straightforward as long as you don't ruin the graft. So this technique has been supported with by the findings of the International Consensus Meeting on Cartilage Repair of the Ankle, and Dr. Ferkel's been instrumental in that, and they agree with this technique and approach for using an anterior approach for bulk allografts. So not too many people do this. What's the outcome? I have 42 patients in my series, but we reported on 20 large graft sizes and 10-year follow-up. 100% of the patients that I operated on said they would have the procedure again. And understand many of these are 3 or 4 time failures. 81% survivorship, but there is a reoperation failure rate that's not insignificant. And that's important to know when you get to this, this procedure. Systematic review was also published 2017, and that features pretty significant clinically relevant improvements in foot and ankle scores, pain reduction, but about a 25% reoperation rate and 13% failure rate. There is concern about salvage of these, but I haven't found that to be an issue. My number one operation for a failed Talus allograft is another one, but I haven't had any problems in conversion to arthrodesis or prosthesis when I rarely have to do that, but that is a concern. And just a couple of examples of cases and patients. We're looking at return to sport with these grafts, and a couple of people here. This one had zero pain in 14 years after the procedure, but isn't doing sports. That's pretty impressive. And this person says, you changed my life after 5 surgeries. So pretty dramatic outcomes can be had with this in people that are multiple failures. And so I believe that osteochondral allograft is a great option when all else fails, or if the lesion is big or missing bone. And I know Dr. Ferkel's talking next, and he can say how many patients we take care of together. I think he would support that contention. Thank you very much.